The MOVE-PD trial with a glucosylcerebromide synthase inhibitor involved 221 GBA-PD patients from global sites, recently reported no significant impact on the progression of Parkinsonism as measured by the MDS-UPDRS 2 and 3 scores. Thus, it seems that more downstream modulation might result in a better outcome in Parkinson's disease, as in the Ambrosio trial. There is another failed disease-modifying trial using a c-Abl tyrosine kinase inhibitor, nilotinib, in Parkinson's disease. Actually, the nilotinib group showed a tendency of aggravation compared to the placebo group in this trial, with no significant changes in biomarkers, suggesting no further trial recommendation with this drug in Parkinson's disease. Another large trial with brain-penetrant c-Abl inhibitor is currently undergoing in multiple sites in the US, Europe, and India. Therefore, we need to keep our eyes on the results of this trial before giving up this pathway modulation in Parkinson's disease. Now, I would want to point out that we are in the era of deep phenotyping of Parkinson's disease patients toward more precise, personalized medicine than ever before. This is an example of new clinical subtyping of predominant motor, intermediate, and diffuse malignant derived from the PPMI data by Ron Postma group. This sort of data-driven approach of deep phenotyping opens our minds to look at the heterogeneity of Parkinson's disease from a more integrative point of view. Therefore, a future deep phenotyping should have a more biological basis linked to the pathogenic mechanism of different clinical features in Parkinson's disease. Furthermore, indeed, the diverse phenotypes in PD appear from the prodromal stage, so therefore we could detect a specific phenotype of prodromal Parkinson and engage a possible specific disease-modifying strategy in that phenotype. This futuristic phenotyping concept is well proposed by Daniela Berg et al. In a review paper published this year. However, there is also a concern for papers trying to report new phenotyping methods in Parkinson's disease. Papers published so far are primarily cross-sectional and data-driven and rarely involved non-clinical biomarkers. So the clinical importance of differences between subtypes, potential treatment implications, and applicability was currently poor. In addition, the temporal stability of subtype and prognosis should also be sought after. Important two things that we do not forget for disease modification in early Parkinson's disease are exercise and diet. Studies have shown the beneficial effect of exercise with either high intensity or yoga and the mere physical activities in Parkinson's disease. Exercise could lower Parkinson's disease risk, improve muscle strength, reduce Parkinsonian motor symptoms, and showed potential disease-modifying effects as well. In addition, the Mediterranean diet seems to delay the onset of Parkinson's disease, especially in women analyzed in a population-based cohort. So let us move on to the next topic, optimize the motor symptom control with anti-Parkinsonian medications. I will begin with this question, when and how to start anti-Parkinsonian medication. When we decide to treat our patients, we must try to meet the therapeutic goal in early stage Parkinson's disease, to normalize patients' daily activity, to improve the quality of life, to delay motor complications, and to minimize non-motor side effects. To achieve this goal, we need to keep an individualized approach in selecting drugs and various regimens. With the help of future deep phenotyping, we will need to consider genotypes and phenotypes shortly. However, as for the present, we must consider, most importantly, patient's age, disease severity at the time of diagnosis, and comorbidity. In addition, we often need to consider polypharmacy, especially in older patients, and economic status in underprivileged patients, and sometimes we have to choose anti-Parkinsonian medication solely depending on the availability in the region. There may be large individual variability in compensatory activities in relation to progressive dopaminergic loss. It is usually over 50% neuronal loss when the patients are diagnosed, but the thresholds of motor symptom appearance are largely variable. In the case with significant degeneration, but with only subtle symptoms, is that beneficial to start later after significant motor symptoms appear out of compensatory changes? We need to consider that the compensatory changes are mostly related to the underlying mechanism of L-DOPA-induced motor complications, as evidenced by literature. Isn't that be beneficial to alleviate those compensatory changes a little by dopaminergic medications earlier? When to start is still a contradicting issue, but it may be reasonable to start with mild symptomatic drugs while keeping disease-modifying exercise in early PD patients with very mild symptoms, especially if they are young. Furthermore, when starting dopaminergic medications, consider choosing the lowest dose to improve motor deficit if possible. However, these subtle motor symptom cases are rare, and more commonly, patients visit clinics or hospitals when they develop obvious motor symptoms. Then, how to start anti-Parkinsonian medications? First, we need to know the strength and weaknesses of each class of drugs and the PK of the drugs. L-DOPA regimens have a potent and reliable effect, whereas dopamine agonists have a moderate effect and some benefit over non-motor symptoms, such as apathy and depression. Once-daily formulations or parenteral drugs are of a particular benefit for some patients. MAOB inhibitors usually have mild symptomatic benefit with questionable disease-modifying value and once-daily formulations. New generation MAOB inhibitors tend to have a more selective affinity, but all these drugs may have potential interaction with antidepressants or other psychiatric drugs. There has been continuous debate on which class of drug first or alone while sparing levodopa. During the past 2 decades, lots of evidence suggests that the long-term outcomes are not different from the class of drugs first used. Therefore, selecting an anti-Parkinsonian drug regimen depends on individual motor symptoms, patient's age, and comorbidity and their preference. We may need a particular regimen for refractory tremors in a tremor-dominant Parkinson's. We can first do first-line and second-line drugs, and in refractory cases, we may consider DBS or MR-guided focused ultrasound. As for the possible disease-modifying effect of early administration of levodopa, this randomized delayed started trial showed no significant effect of levodopa first therapy. So there is no justification for either early administration of levodopa for disease-modifying purposes or delaying levodopa treatment. From the view of this trial, a cumulative disability concept was proposed, emphasized on disability produced by delaying levodopa administration. If we know the predictors of motor complications, it will be very good for a prognostication in individual. Younger age and higher dopaminergic medication dose is a well-known strong predictor, and lower strata that higher when stages at the time of diagnosis is another good predictor. Interestingly, initiation of levodopa at later disease stages could predict motor complications within weeks. Other weak contributing factors include low BMI, female gender, and genetic susceptibility. Considering all these factors, we need to pay particular attention to young onset Parkinson's disease patients, as they have about 2.5 times higher risk of developing motor complications than old age patients over 70 years. In addition, they also have a high risk of impulse control disorders that cannot be ignored when prescribing dopaminergic medications to young onset PD patients. Dopamine agonists have a greater risk than levodopa for excessive daytime sleepiness, leg edema, impulse control disorder, or other impulsive behaviors. L-Dopa is inevitably added to L-Dopa sparing therapy to control motor symptoms after a few years of treatment. The early use of dopamine agonists may reduce the cumulative dose of levodopa and have some long-term benefits on dyskinesia. However, this advantage may be reversed by that the efficacy of motor symptom control is more favored to levodopa, evidenced by longitudinal data. The long-term effect on motor complication has not differed between levodopa-treated and spared group in a pragmatic world, unlike the clinical trial setting. Moreover, the long-term disability in Parkinson's disease patients was not driven by dyskinesia, but driven mainly by false freezing, dementia, and psychosis. MAOB inhibitor monotherapy is often considered in early PD patients with very mild symptoms. However, it often may not be sufficient as the disease progresses. MAOB inhibitor with dopamine agonist therapy may be an option to improve motor symptoms before adding levodopa in young-onset PD patients, while it could reduce dopamine agonist dose as well. In order to draw the best treatment guidelines for young-onset PD patients, clinical trials specifically for young-onset early PD patients are needed. Unlike the young-onset PD patient, we should consider the comorbid medical condition, vascular or other comorbid degenerative condition, polypharmacy in old-age PD patients. As a result, levodopa monotherapy is preferred in this population. Finally, I would mention this recent study reporting paradoxical peripheral aromatic acid decarboxylase induction with chronic levodopa treatment in PD patients. Interestingly, AADC activity increase was more significant with higher dose and longer duration of the disease. Thus, the peripheral AADC induction may underlie a waning effect of levodopa over time, as mostly seen an increase of LED in our patients over time. There is also a discovery of gut microbiota that can metabolize levodopa in humans, and the phenomenon can be reversed by administering AFMT, as the low bioavailability of the current levodopa DDCI regimens. This finding could provide a new way to improve the PK of the levodopa drugs. We should also note levodopaphobia by some patients and even by physicians, which ultimately leads to poor outcomes. A recent paper by King's College Group described levodopaphobia explicitly and suggested a management guideline to help doctors manage patients with this tendency. Lastly, we also need to understand what patients concerns most at different stages of the disease. For example, tremor is the most troublesome symptom in the early stages, whereas balance and falls are the most concerns in late-stage patients. Therefore, we need to make patients understand the nature of PD tremors and develop better therapeutic options for tremors on the other side. In summary, we are more closer to achieve modifying disease progression. However, we still need to develop early detection methods, precise phenotyping, equipped with precise biomarkers to identify and monitor disease progression. And finally, we need to succeed in developing disease-modifying agents. We can now optimize motor symptom control while delaying motor complications and avoiding non-motor complications at our best with a variety of anti-Parkinsonian drug regimens. There is no unified guideline, but kept individualized approach under some principles. Future development of personalized medicines with a biological or pathological basis would enhance our understanding of the diverse phenotype of Parkinson's disease and will be able to treat patients more comprehensively in the future. Finally, I'd like to thank my colleagues in Seoul National University and affiliate